I'm Dr. Q Del Rosso from Las Vegas, Nevada with Derms Squared, the Derms and Conditions podcasts. And this is a very, very monumental day in the history of Derms and Conditions, because we are now starting Tea with Dr. D. And Tea with Dr. D signifies that this is a video podcast, or what's called a vodcast. And I looked long and hard to find someone that I wanted to be the first person to do a video podcast. And I came across this. I think she's phenomenal. I've watched some videos. She's gone to notoriety from, just coming into dermatology to being at the top of the heap in hidradenitis suppurativa. And probably in the next 6 months, everybody that has that disease in Canada is going to already be deroofed within her office. And she's gone from zero to the heights faster than Taylor Swift did in the music, okay? So the pressure is on Dr. Lauren Lam. She's in private practice in Calgary, Alberta, in Canada. And it's great to have you here, Lauren. Thanks for being our first video podcast.
Thank you so much for having me. I feel really honored, especially as a Canadian, to be joining and to be the first tea with Dr. D.
First tea with Dr. D. What do you mean, as a Canadian? I mean, Canadians are pretty good people, aren't they?
I'd like to think so, but I mean, the Canadians always are like a little more on the down low, a little bit less prominent, let's say, than you are, that's for sure. So.
Well, certainly not on the down low. Every time I look on LinkedIn, you're somewhere, teaching someplace, and it's exciting. You're really teaching a lot of people about hidradenitis suppurativa, and I'm happy about this being the first disease state that we're focusing on with the Tea with Dr. D video episodes, because it really is a disease state that just lagged because we didn't have a lot of treatments. It was a very, very challenging. Most of my career didn't have anywhere near what we have now with the advances in the therapies and even some of the surgical approaches. You don't have to remove the entire axilla, to treat hidradenitis suppurativa. So I want to go through first with you, focusing on the diagnosis and the encounter in the office. So patients hear about, a lot of the times they're referred to you because people know that you concentrate on that disease state, but you might have patients in the community that are just coming in and seeing you for the first time that are new with hidradenitis suppurativa, but most of them have been around the block for a while. And so they're coming in to see you. So how do you organize it in your office? Because there's a lot of information you need to get up front, but you also have to be time efficient, within the practice. So you have intake forms, or you have your staff trained. How do you do that?
Absolutely. It's a complex disease, so I think that's been one of the barriers for treatment. So the way that we have it set up at our clinic, and we are a center of excellence for hidradenitis suppurativa, actually. So our nurses are quite well trained and well versed in HS. So we tend to actually have dedicated slots for new HS patients. And we actually have intake forms that you can actually access them as well from the Canadian HS Foundation website. So it has all the types of relevant history questions that you would want to know at a snapshot: comorbidities, antibiotic use, flares, chronicity, these types of things. So you can just find out. So
it's organized. It's organized on a form that you can get from the Canadian Hidradenitis Suppurativa Foundation for electronic medical records, right?
Exactly.
So it makes it very facile. So that's accessible to anyone if they go to that website, correct?
Exactly.
Right. So let's go through some examples of. So you're going in the room for the first time. And I'm just thinking I'm putting myself in the mind of a patient. I don't have this particular disease, but have seen many people with it, thinking, okay, what's this lady going to do different than the 5 other places I've been to, or 10 other places I've been to, even dermatologists, that she's going to do differently for me? They're tired of it. A lot of them have anxiety, depression. Many of them are overweight, right? right? That's very,
Yeah.
very common. And so there's a lot of challenges there. And so how do you approach with them to make that connection?
Right. So there's been some discussion about whether or not every dermatologist will want to do this, but I found this extremely effective and actually practice changing. So we have a video that the nurse plays in the room for the patient, which just generally goes over what is HS, what are some common comorbidities, what are some common treatments. And actually, I find that patients really like that because they know that we are familiar with this condition, that we're a dedicated clinic that knows how to treat it. So I think number one, that helps with practice efficiency, but it actually helps to gain their trust because they know that you're familiar with this. So it really cuts down on my time when I'm with them in the room, but when I'm in the room with them, I really try to get a sense for how sick of this are you? I think as dermatologists, oftentimes we decide whether or not a biologic is appropriate for a patient. But in these cases, you might be seeing them when they're not flaring. And it's surprising how quiescent and innocuous it can look sometimes. So when I'm in the room, I just really try to focus on where are they at in terms of the cycle of frustration and what can we do next? What's the next bang for our buck that we can do?
Right. So you're not just necessarily looking at them and thinking what therapies am I going to select? What I call the playing doctor, what we typically do in our own heads.
Right.
You're looking them straight in the eye and letting them know, this is a miserable disease, even if you're not feeling miserable right now. And you want to make sure that you address that. So if it's a lot to deal with if they're telling you I'm very depressed, and you can see that obviously that they're overweight. You can't handle that all at that first visit, right?
No.
It becomes overwhelming. So do you just do that over time? How do you address that with them?
So I try to really just focus on severity, and then in my mind, what is the best bang for their buck for today's visit? Of course, you can always talk about things like weight and smoking cessation and all the other lifestyle things. But if we're seeing a Hurley stage 3, those things aren't going to make the biggest difference for this patient. A biologic in this case is going to make the biggest difference. So I really focus on that. So knowing that you're going to eventually be seeing them a few times, maybe eventually you can broach those topics. But oftentimes I try to just focus on what's today's goal. Next time we'll focus on something else if we continue to get better and better.
So they know you're going to get to it, but let's get started with what we really need to do right now, and then we can address these things. You don't have to try to take over the world in one visit, right?
It helps to gain their trust because if they see that the one choice that you made for them in the first visit really made a big difference, okay, well, maybe there's other smaller things that we can keep hacking away at, right?
Yep, exactly. Hacking away. That might not be the best choice of words.
Oh no, for a deroofing
we're gonna deroof it away. So let's talk about some of the comorbidities that you might be seeing and addressing with some of the other therapies that may not be biologics, like inflammatory bowel disease. How often do they have arthritis and psoriasis related to it, or some other inflammatory disease? Right? How often? Some of those you try to identify right away?
Right, yes. So those are in the screening templates, but I try to really screen for those three things. Inflammatory bowel disease, which is the most common comorbidity. And in fact, a lot of patients are referred from GI to me because HS is so highly inflammatory. They're actually on a biologic already and still flaring with HS. So that really changes what you are thinking about in terms of your options, right? It limits your options. Go ahead.
No, I'm just thinking early on, because you read a lot, and sometimes when I'm reading it, the article's written as if, how come you dermatologists or people out there, clinicians, take so long to diagnose this disease, and the patients have it for years. And I'm thinking about when a lot of these patients first come in, they may have just an isolated lesion somewhere that you think is an abscess or an inflamed cyst, and they have HS, but how are you going to know it that early. When that happens, when you're seeing patients with these areas that are very limited in involvement, when is it triggering in Lauren Lam's head? This might be an HS patient, a hidradenitis suppurativa patient.
So I'm actually going to quote my colleague who's in down the hall from me, Dr. Susan Pullman. She has a nice phrase. She says 2, 4, 6. So 2 lesions for more than 6 months in the typical areas or typical body sites. That's a nice, easy, quick way to think about that, although definitely not encompassing for follicular subtypes, for example. And I've seen HS everywhere in the body. I've seen it on extremities, on the back, on the chin, on the neck.
But how do you know that's
Ears.
HS? Does it have to also be in the common areas?
Not necessarily. So I think for me, the chronicity is really the kicker. By the time they see dermatology, at least in Canada, because it takes a little longer for patients to see us, they have definitely had this for at least 6 months, if not years. So chronic folliculitis on the bum cheeks is probably not chronic folliculitis, right?
No, that sounds painful. And it is painful, right? Before we get on to some features of the physical examination that can help you differentiate certain situations, what things come up in the differential diagnosis that you might miss, right? Like I think about cutaneous Crohn's disease or other lesion types of lesions that can happen, especially in the genital area. What should you be thinking about other than HS as far as differential diagnosis?
Right. So you could be thinking about STIs. So lots of them can appear as a single lesion. That would be one good differential. I was going to mention cutaneous Crohn's, but you took it out of my mouth. I mean, you can get, the ones that people tend to mistake things for, like folliculitis, ingrown hairs, for example, even just cysts. If it's a solitary lesion that one time, that can be mistaken as well for HS.
So now the physical examination. So you have a patient, you feel comfortable with your diagnosis of hidradenitis suppurativa. What are some of the things you look for and actually do in the physical examination, other than have patients hold their arm up or lift up their breasts or show you in the groin folds, whatever the case may be? What do you look for that really help you diagnostically or therapeutically?
Right. So everyone talks about the double comedone being pathognomonic, but up until the point where I started doing deroofing, I didn't really understand why patients had double comedones, and now I realize that actually they're very, very superficial sinus tracts. So the sinus tract lining actually becomes psoriasiform over time. It starts to shed keratin, and the shedding of the keratin, in this case for a double comedone, when it becomes oxidized, that's what you're seeing for a double comedone. So everyone knows about that, but the trick to that is that because that is a sinus tract, technically, if we're speaking on technical terms, you can upstage a patient now, right? Because now you're seeing sinus tracts.
Right.
I think the most valuable thing to do on exam is actually palpation. A lot of us are afraid to touch these patients because of the areas, because it's draining, because it's painful. But you'd be surprised how much more extensive the scarring is when you just do some light palpation. It feels ropey, almost a little bit fibrotic sometimes, and you'd be surprised when it looks like nothing and you do some light palpation. It's very extensive.
So you mentioned follicular subtype.
Yes.
And just going back to what you just said, there's a lot that lies beneath that you can't see, and that's a lot of times where it's a lot more than skin deep, and it goes a lot of different directions beyond where you might be seeing something visibly. But you mentioned the follicular subtype. Can you explain to me what that is?
Yes. So when you look at it, essentially you're seeing acneiform papules that are folliculocentric. but in areas where you wouldn't necessarily expect chronic folliculitis. So gluteal cheeks is a very classic one, I find. Sometimes the axilla, and again, people tend to mistake these for ingrown hairs because oftentimes women are getting waxing, for example, done in these areas, or they're shaving, so they mistake it for that.
So when we're thinking about therapy, I mean, I was always one that believed when we were putting topical therapies on, topical clindamycin, or telling people to utilize a benzoyl peroxide cleanser, or then people were talking about resorcinol and some other formulations.
Yes.
I always felt like this is more treating me than it is the patient. I always felt like the topicals weren't doing much, though sometimes people would say, hey, you need to give me a refill. In their mind, they thought it was helping, and maybe it is, but in terms of severity and treatment selection and getting beyond even oral antibiotics over and over again, which I think only do so much and don't really shut down what's happening underneath as much as we would hope for. So how do you do that? How do you determine the severity from your physical exam and everything you're seeing and hearing that leads to treatment selection or optimized treatment selection?
Right. So there's actually a really good paper that we can link in the description that breaks down mild, moderate, severe. It's a little trickier though when you throw in things like follicular subtype, because to the eye, to the dermatologist, it doesn't look that severe. But I try to go by general Hurley staging for mild, moderate to severe, just to give me a bit of a guide. So scarring or non-scarring. So you're going to do the palpation to see if there are sinus tracts and scarring. If there are, then I think this is a bit of a mindset shift we need to take with HS. I find a lot of dermatologists are quite conservative in their treatment, and they tend to give patients, as you said, topicals over and over again, oral antibiotics over and over again. But I think we need to be shifting our mindset to say, hey, if this is quite chronic, if the patient says, I'm really sick of this, we should be thinking about better long-term preventative solutions, i.e. things like biologics, right? Or
and treating what lies beneath, right?
Exactly. Because just like if you were to see an acne patient and, some moderate patients, you're going to be starting on isotretinoin because it's almost that gestalt feel where you want to prevent scarring. We should be thinking about HS in the same way. We should be preventing. Right?
People that are obsessive about the lawns in their home, they don't only pull the weeds out, they're putting all kinds of weed killer down and things that's treating what lies beneath, right?
It's true.
So, it's the same type of concept.
Absolutely.
So, now, utilizing biologic agents, which we're obviously going to get to in a little bit, that treats the follicular subtype too also?
Yes.
Right?
Yes.
Right?
I have had some patients that I've started on a biologic and it's bothersome enough to them and they actually respond really well to it. Pretty much total clearance.
So I want to wrap up this first episode we're going to do. We're going to have a part 1 and a part 2 with 3 different areas because, I'm thinking back for something like intralesional triamcinolone, intralesional corticosteroid injection. Right. And, when you do that on the face for acne, you're giving small amounts and you're afraid you're going to leave an atrophic area and but if you utilize those 2.5 milligrams per cc whatever that you might use on a nodular lesion on the face to try to treat a lesion in the axilla or the groin that's deep, you're doing nothing, right? It's like
Absolutely.
So my understanding is we use much higher doses, 20 to 40 milligrams per cc, when we're injecting lesions for hidradenitis suppurativa. So can you go through with us and show us how you do intralesional corticosteroid injection for hidradenitis suppurativa?
Absolutely. So guidelines say that you can do 10 to 20 milligrams per cc. I tend not to do more than 1 cc per lesion. And really, you're trying to aim right into the dermal area so that you're getting right into the lesion. There's actually a video that we've made with the Canadian HS Foundation, so we can also link that YouTube video that actually teaches you how to do an intralesional steroid and how to mix up the steroid if you're using 40 milligrams per cc.
So you probably put a topical anesthetic on, correct? Before.
You can, yep.
And how long does that have to sit typically before you're going to inject?
So I tell patients 45 minutes, knowing that they're probably not going to do 45 minutes, but you obviously want time for it to be effective. And these are so tender. You really want to give yourself as much anesthesia as possible.
So they put that on before they come in, and
Yes.
so they have that in place. And then when does the deroofing come in? I mean, you might not even discuss that at the first visit, right?
It's in our video, so it does mention deroofing if appropriate. And usually, if let's say I feel that the biologic is the best step for today's visit, then I'll say, at our future visits, we'll definitely talk about deroofing more. But here is a handout with a QR code that goes over what is deroofing, and they can read about it, at least so that they're primed, so that the next time they see me, it's not a totally foreign concept to them.
And they can write down their questions and get them addressed.
Exactly.
So what about incision and drainage? When do you incise and drain a lesion? Because it's like epidermal cyst in the sense if you don't get the cystic, this is obviously not that type of lesion. It doesn't have a capsule around it. But if you don't get everything out that you need to get at the time of the IND, the lesion just recurs, correct?
Exactly. Actually, there's 100% recurrence for IND with HS. So I use it mainly for pain relief. If someone's coming in with a huge abscess, I do the IND for the pain relief from the volume release, but I always make sure that I inject more steroid into the area after you've drained it so that you're actually getting the anti-inflammatory effect that you're really looking for.
So you're utilizing the incision and drainage along with intralesional corticosteroid injection,
If
both of those
appropriate, yes,
together,
yeah.
right? Okay. Now, what about good old laser hair removal? Because patients will ask about that. Do I need to get rid of these hairs? Are they contributing to this problem that I have? So, what do you do with laser hair removal? Does it actually help? Does it make it worse? Right?
So there's actually a poster that was presented at the Symposium for HS Advances 2 years ago that showed that you can actually get a high score, or basically 50% improvement, in 70% of patients with mild to moderate HS, which is way better than any biologic that we have. So, I think people have always known anecdotally that it works well because the theory is that it destroys some of the glands and the sites where the HS is getting occlusion, right? But yes, it makes a huge difference. My patients definitely notice.
Is there anything specific about how that laser hair removal was done, or any particular machine or setting that made a difference with getting that result? Or was it just randomly across the board, however anybody was doing the laser hair removal?
So most studies are looking at herb-YAG lasers, but essentially they're being put at laser hair removal settings. Okay. So nothing special, but one tip is that you can also give patients topical numbing as well prior to their visit. Because you've got flares happening in between, this just helps to make it more bearable for the patient. And your technician can then actually work around the flare lesions.
Right. And so this is typically something that the patient pays out of pocket. It's not covered by insurance, correct? I know Canada might be a little different than the United States,
yeah.
But,
So I do ask my patient if they have what we call a healthcare spending account here in Canada. So worth asking if your patients have that too, that they can submit the receipts to insurance. And, sometimes they need a letter, but you can get it covered because it's medical in this case. Yeah,
healthcare spending accounts exist in the United States. I I don't see that they've taken off, extensively, but if
Right.
people have it, it can certainly help. Lauren,
Absolutely.
thank you so much for the conclusion. I'm sad now. I'm getting verklempt. I'm getting very, very sad that the part one of our two-part podcast series, video podcast series, has come to a close, but we
But
have
there's
part
always
two.
part two.
There's always part two, so we're not done yet. But I think that was excellent, and I appreciate the graphics and videos that you provided.
Thank you so much. I hope it was helpful, and I'm really hoping that the videos in part two are going to be exceptionally helpful for helping people decide whether or not they should incorporate it in their practice.
Sounds good. See you soon.
See you soon.